Hello everyone, welcome back. Today I'll be covering TB, tuberculous spine, my simplified version. This includes introduction and natural history of spinal TB, regarding paradiscal, anterior and central lesion, pathophysiology of TB spine, disc involvement and vertebrae involvement, the diagnosis of TB spine, CDC recommendation regarding Mantoux test, the role of X-rays, CT scan and MRI, the outcome of treatment. Now let's get started. As an introduction, common site for skeletal tuberculosis, 50% are in spine, 5% in cervical spine, 25% in thoracic spine, 20% in the lumbar and lumbosacral spine. Around 10 to 45% has concomitant neurological deficit. In immunocompromised patient, example in diabetes mellitus patient, end stage of renal patient, patient on prolonged steroid, HIV and IVDU, intravenous drug user has higher risk of getting tuberculous spine. The natural history of spinal TB. Spinal TB is a chronic manifestation of the infectious disease. Again, it is an insidious disease. The time from symptoms to diagnosis can be around 3 to 6 months, sometimes up to 12 months. Remember, only 20 to 30% of the patients with spinal tuberculosis have constitutional symptoms. It has an insidious progression with 3 major clinical features. 1. Cold abscesses. 2. Neurological deficit. 3. Long-term kyphotic deformity of the spine. Cold abscesses are collection of purulence originating from the infected vertebrae without surrounding inflammatory response. That's the definition. Vertebral lesions of spinal tuberculosis include paradiscal lesion, anterior lesion, central lesion. For paradiscal lesion, it is the most common. The primary focus of infection begins in vertebral metaphysis and erodes through the cartilage and plate. This causes extension of infection to the next adjacent vertebrae under the anterior longitudinal ligament. Thus, this leads to progressive resorption of bone on either side of the disc. The kyphosis thus produced is fairly severe. This figure illustrates the common TB vertebral lesion that consists of 1. Paradiscal at the area of the end plate, 2. Anterior beneath the anterior longitudinal ligament, 3. Central, center of the vertebral body, and 4. Appendiceal at the area of neural arch region. So again, it is based on location. Anterior lesion in TB spine is under anterior longitudinal ligament ALL, usually confined to the anterior aspects of the vertebral bodies. It causes elevation of ALL, anterior longitudinal ligament, and allow for extension of the infection to adjacent vertebral body without penetration of the disc. Bony destruction is superficial and the deformity is not severe. For central lesion in TB spine, the infection starts in the center of a single vertebral body and usually does not spread to other levels. This leads to collapse of the vertebral body and often mistaken as malignancy or pathological fracture. Regarding pathophysiology of TB spine, the spread occurs either via the arterial or venous route. Anterior and posterior spinal arteries in the subchondral region of each vertebrae facilitate hematogenous spread of infection in paradiscal region. Batson's paravertebral venous plexus in the vertebra is a valveless system that allows free flow of blood in both directions depending upon the pressure generated by intra-abdominal and intrathoracic cavities following a strenuous activities like coughing. This figure shows the Batson venous plexus. Again, Batson paravertebral venous plexus is a valveless system that allows a free flow of blood in both directions depending upon the pressure generated. The spread of infection via the intraosseous venous system may be responsible for central vertebral body lesion. In the paradiscal lesion, infection spread through the arterial plexus. Intraosseous and extraosseous abscess formation are often found in this lesion, which is major risk of cord damage due to pressure effect by the abscess or displaced bone or ischemia from the spinal artery thrombosis. In central lesion, it spreads via Batson venous plexus, as discussed previously. Regarding the disc involvement and vertebrae involvement, in younger patients, the disc is primarily involved because it is more vascularized because of end plates. In old age, the disc is not primarily involved because of its age-related avascularity. In spinal TB, there is involvement of more than one vertebrae due to 1. Segmental arteries bifurcate to supply to adjacent vertebrae. Number 2. The spread of disease beneath the anterior or posterior longitudinal ligaments involve multiple contiguous vertebrae. Number 3. A lack of proteolytic enzymes in mycobacterial infection as compared to pyogenic infection has been suggested as the cause of subligamentous spread of infection. This figure shows longitudinal organization of the arterial blood supply in the spinal cord. The segmental arteries derived from the aorta reach the spinal cord surface and form the anterior spinal artery, ASA. There is also an artery of Adam-Kiewicz, the pial artery plexus, the segmental artery, and in front then is the abdominal aorta. Regarding diagnosis, the diagnosis of spinal tuberculosis is made on the basis of typical clinical presentation. I emphasize that along with systemic constitutional manifestation, evidence of past exposure to TB or concomitant visceral TB, and imaging modalities. Skin tests and hematological investigation like full blood count (FBC), erythrocyte sedimentation rate (ESR), Mantoux test, enzyme-linked immunosorbent assay (ELISA), and polymerase chain reaction (PCR) are done. Bone samples or tissue samples are obtained and stained for acid-fast bacilli (AFB) and isolate organism for culture, sensitivity, and histopathology, either by using a CT-guided or ultrasonography-guided needle biopsy. CDC recommendation about Mantoux test. Number 1, less than 5 mm is negative. Number 2, more or the same 5 mm is positive for a person with A. HIV infection or risk factor for HIV infection with unknown HIV status. B. Close recent contact with infectious tuberculosis cases. And C. Chest radiograph consistent with old heel tuberculosis. 3. More or same 10 mm. Positive for person with an increased prevalence of tuberculosis infection. That means foreign-born person, medically underserved low-income population, or with medical condition. Example, insulin-dependent diabetes, end-stage of renal failure, malnutrition, immunosuppressive illnesses, intravenous drug user. Number 4, more than 15 mm is positive for anyone with no risk factors for tuberculosis and a member of low incidence group. What is the role of X-ray? Plain radiographs are usually the initial investigation in spinal tuberculosis. For a radiolucent lesion to be apparent on a plain radiograph, there should be 30% of bone mineral loss. Again, the role of X-ray is 1. To confirm the level of spine involvement. 2. To look for the number of vertebrae involvement. 3. To look for skip lesion. 4. To look for paravertebral abscesses. 5. To estimate the severity of kyphosis. Again, this plain X-ray lateral view of the spine shows a kyphotic deformity at the thoracolumbar junction. CT scan, computed tomography in TB spine. CT scan provides much better bony detail of irregular lytic lesion, sclerosis, disc collapse, and disruption of bone circumference than plain radiograph. It is more effective in defining the shape and classification of soft tissue abscesses. However, CT is less accurate in defining the epidural extension of the disease and its effect on neural structures. The pattern of bone destruction, fragmentary, osteolytic, sclerotic, and subperiosteal can be seen well on CT. This figure shows the pattern of bone destruction in TB spine. The uppermost on the left-hand side shows the fragmentary type or pattern, subperiosteal beneath the periosteum, osteolytic lesion, and localized with sclerosis. CT scan is ideal for guiding a percutaneous diagnostic needle in potentially hazardous or relatively inaccessible sites. The presence of calcification within the abscess is virtually a diagnostic of spinal TB. In the past, CT myelography was one of the modalities used for spinal TB for assessing a cord compression, but it has been replaced by MRI. This shows the bilateral tuberculous was abscess with peripheral calcification. It is important because it's virtually a diagnostic for spinal tuberculosis. Next, MRI characteristic findings in TB spine. These include destruction of two adjacent vertebral bodies and opposing end plates, destruction of intervening discs, vertebral body edema, vertebral wedging or collapse, spinal deformities, the occurrence of prevertebral, paravertebral, and epidural abscesses. MRI plays an important role in the diagnosis of spinal TB with a high specificity and sensitivity. This MRI T1-weighted sagittal MRI shows a destruction of L2 and L3 vertebrae with epidural abscess. Outcome of treating the patients with the following option. Either one chemotherapy alone or chemotherapy and debridement, chemotherapy and radical debridement plus anterior fusion. It has a same outcome. No late relapse or late onset paraplegia. The only advantage of the radical operation was less late deformity compared with debridement. This is by a 15-year assessment of control trials of management of tuberculosis of spine in Korea and Hong Kong, a 13 report of the Medical Research Council MRC Working Party on tuberculosis of the spine. So what is the operative treatment? The indication is 1. Large abscesses. 2. Progressive neurological deficit. 3. Instability. 4. Not responding to chemotherapy. 5. Progressive kyphosis. Please take note. Yay! We have reached to the end of this video. I hope it helps. See you in the next one. Take care and bye.